Hello, my name is Dr. Marvin Langston. I am an assistant professor in the Department of Epidemiology and Population Health at the Stanford School of Medicine. And today my talk is focused in on a often neglected population, sexual minority men in prostate cancer. And so I call this talk kind of prostate cancer prevention and control among sexual minority men, an emerging field in health equity research. So just a brief overview of some of the topics that I hope to cover here in this talk. First, I really want to give an example of collecting sexual orientation data. How is it done, both in large population-based research studies, and also how does it get input into clinical electronic health records. Then I also want to talk a little bit too about the risk and benefits of sexual orientation disclosure for men. Then starting to get into a little bit more of the research landscape in this area. So most of the work has been focused in around prostate cancer screening and also treatment-related side effects post-treatment. And so those are some areas that I will cover. I want to also point out this is not an exhaustive or comprehensive overview in any way. These are just areas in which are important, and there's very little research that's been conducted in these areas and areas of interest to me in my lab, my group here at Stanford. So capturing sexual orientation in population health studies, I feel like there's some terms that we need to really think about as we're going through this talk here. One is that there are many ways in which we can capture sexual minority groups. One is by self-identification. I think most folks are pretty familiar with this. You know, how does one identify one's sexual orientation? Straight, gay, bisexual. Then there's sexual behavior. This has been seen in a lot of the HIV literature, thinking about who folks engage in sex with. So individuals of the same sex. A lot of folks have heard of the term men who have sex with men, women who have sex with women, different sex or multiple sexes. And then finally, probably one that it's not very familiar to folks is the sexual attraction or the sex or gender that someone feels attracted to. And we often think of these categories, these three, as completely overlapping. But in reality, folks' lived experiences might be a bit complex. For example, someone may identify as straight or heterosexual and have sex with both men and women and be attracted to feminine presenting individuals irrespective of sex. So how do we assess typically sexual orientation from questionnaires in the literature? Really, it's just this is the most recent characterization used by the Centers for Disease Control and Prevention. Do you think of yourself as, and then having the categories, as we talked about earlier, of sexual orientation? This is kind of the most standard view that you'll see in the literature. But then collection into the clinical setting can be a little bit more complex. So how does sexual orientation information get entered into the electronic health record? We see here that there's many different points of entry from folks individually self-reporting either before they arrive in clinic or in some online system, or being, once they've showed up to a clinic, being put into their electronic health record via just a visit at the provider point of contact. So there's different ways in which these have been collected. And as you can imagine, in terms of thinking about using these information for research or for clinical excellence markers, it's difficult because of those multiple routes of entry into the system. So how does sexual orientation, in terms of what do folks disclose, or the thoughts of disclosure among sexual minority groups? So there was a study, actually, a national study done, and this included both folks from the LGBT community and also non-LGBT patients and providers. And as we can see here, disclosure is, or the thoughts around disclosure in the clinical setting, it can be very complex. So we see that and this item here on the left, we see that patients would be offended by sexual orientation question. That question was posed to both patients and providers. And we see that patients, agree that at 10.5% that they might be offended by that sexual orientation question. Providers, on the other hand, their perspective, they think that around 80% of patients would be offended. And then there's the refusal question. Would patients refuse to provide their sexual orientation in the clinical setting? Again, we see a wide disparity in the perspectives of both patients and their providers, where patients, they agree they will refuse at about 10%, and then providers believing that they would not disclose their sexual orientation at about 80%. And then across studies of sexual minorities, individuals disclosing sexual orientation or same-sex practices to a healthcare provider, in general, range from about 35 to 88%. Now, that range is fairly wide, and we can see from this study taken from Simon Rosser's Restore study that disclosure among sexual minority men with prostate cancer is actually pretty complex. So this large study shows that a large majority of sexual minority men would actually disclose their sexual orientation to primary care physicians or clinicians, noted by that red bar there in each of these. And this is kind of disclosure being out or semi-out or not out. And in terms of other types of care, they don't necessarily show that they would disclose at the same rate to those clinicians. So for example, for surgeons, oncologists, those folks, or urologists, those folks that may be involved in cancer care, in terms of being out or disclosing your sexual orientation, it hovers nearly at 60%. And then you see it for primary care is nearly 80%. So it can be complex. And so you can think about how this may affect what data gets into certain systems. And so in health systems where primary care is kind of not coordinated with specialty care, this may impact knowledge of sexual orientation across. But kind of why do we care about disclosure, right? What are some of the benefits and what are some of the risks to disclosing sexual orientation in the clinical setting? One of the greatest benefits I see here kind of is this increased trust in the patient and provider relationship. The sexual minority community has really been, has a lot of medical mistrust, some of it stemming back from the HIV, or the early HIV epidemic. And so increasing that trust can be seen through disclosure. But on the other side, in terms of risk, really some thoughts around this is that the patient may be susceptible to homophobia or perceived homophobia. Again, another benefit would be just a tailored discussion of the sexual side effects of whatever treatment decision that the patient decides. And that will help to highlight, and we'll talk about a little bit later, maybe some tailored thoughts on what their treatment should be based on some of their decisions. And then there's this opportunity for less decisional regret. We see this with prostate cancer quite often among all types of patients, but both in sexual majority and minority communities. Patients, after experiencing treatment-related side effects, really having a high amount of decisional regret. And so some of the thinking around disclosure is thinking that if we can tailor treatments in a way that is beneficial, provide more information based on some of the recent literature that's been put out in terms of this community and prostate cancer care, then there may be less opportunity for decisional regret. And then, helping bring the partner into the clinical care experience. I think one of the really deleterious issues in prostate cancer care for sexual minority men is that partners in cancer care are often seen as invisible in the healthcare system. So, and partners need support too through this process. And partners also play a very critical role in kind of mediating the impacts of treatment. And we can think about this in terms of heterosexual men. So for heterosexual men, social support and care navigation is often aided by their wives. And this support has led to really differential benefits and survival for married men versus unmarried men. And it's really currently unclear if the same survival benefits are there for partnered versus single sexual minority men. And then another kind of benefit here is just enhanced data for clinical improvement and research. And we've talked a little bit about that already. And then finally, another risk of disclosure here is the provider does not understand the clinical value of disclosure. A lot of the research in the prostate cancer field in terms of sexual minority men is evolving, and there's still a widespread lack of education in terms of the benefit of knowing this information. And so I think we can, and we'll talk a little bit about some of the differences in the prostate cancer care experience, but really trying to think about provider education in that space is really important. So I've been alluding a little bit to this field, but I really want everyone to get a good sense that this is really an evolving area of research. And we see some of the first papers that come out in this space, around the turn of the century. But research has really been vastly growing in this field. And really one of the hardest issues in the field right now is that sexual orientation is not captured in most cancer registries or in many of the large cohort studies. So it makes it very difficult to estimate the current incidence and prevalence and mortality of prostate cancer among sexual minority men. And so we really need more good data in this area. I'm going to go to a little bit of thinking about prostate cancer screening in this group, and then we'll talk a little bit about a study that we completed in my group on this topic. But there's been previous studies that have used large data sets, such as the National Health Interviews Survey and the Behavioral Risk Factor Surveillance Survey, and they both have showed actually kind of conflicting results. So in the Burford study, they looked at gay and bisexual men, and they showed that they have a higher rate of or higher odds of screening than straight men. And then in the other, in his study, they kind of showed that there was no differences in PSA screening between gay and bisexual and heterosexual men in 2018. But prior to this, they looked at previous waves of these surveys, and they kind of saw that gay men have higher odds of screening. And so with those large studies, they're both really based on cross-sectional data, self-reported screening as well. And they also don't really account for sexual behavior. They only look at kind of orientation or identity. And so we decided then to, in order to look at that and kind of think about those methodological issues in another large study here in California. And so we did a PSA screening study and looked at PSA screening history in the California Men's Health Study cohort. It's a study cohort that is built from the male Kaiser membership, Kaiser Permanente here in Northern California. And the patients self-reported sexual orientation through questionnaire data was used along with long-term clinical screening information through the electronic health records at Kaiser. And so this study had some advantages, some of them being able to capture both sexual identity and sexual behavior, as well as being able to capture other important covariates, and then looking prospectively at the screening behavior. So we saw here that PSA screening assessed from both, as I said, survey responses and kind of enhanced by the electronic health record information. This is just the characteristics of the cohort. Really, I have this slide included just so that you can see that this is a really big cohort and with a modest amount of sexual minority men, considering both sexual identity and sexual behavior. What we found was that sexual minority groups were less likely to participate in prostate cancer screening, and it's interesting when you kind of compare what we have here. Sorry, let's go back there. It's interesting when you compare kind of what's happening here with other large studies that have been done in this area. They're likely these differences are likely kind of reflective of using a very well-defined cohort that we used here. And this idea of using both self-reportive screening that others have used, but also enhanced by the actual clinical record, the EHR evidence of testing. And so our next analysis here is to kind of assess the screening patterns over time to look at when the United States Preventive Services Task Force has kind of changed screening guidelines and how that impacted screening. So moving a little bit from screening into the prostate cancer care experience for sexual minority men, we find some pretty stark results here. We see that for erectile functioning, sexual minority men kind of reported better post-treatment erectile functioning, and these sexual minority men have also reported more bother from erectile dysfunction. And so it's interesting, they reported better post-treatment functioning, but yet more bother from this. And it's interesting, this is likely due to an expectation of long sex life into later years for these groups, and loss of an opportunity to explore recently accepted sexuality, or also this concept that a firmer erection is needed for anal intercourse compared to vaginal sex. And I'll talk a little bit more about that in a moment. But also, there's been other studies, and I've cited some of them here at the bottom, that have looked at sexual urinary functioning among sexual minority men. And we've seen that sexual minority men reported worse urinary and bowel function, a lack of ejaculation, climacturia, which is basically urine at climax, penile shortening, so loss of actual length and girth of the penis, more loss of libido, and reported less frequency of sexual activity. So we can see that these treatment-related side effects, it's really interesting to look at these differences within this population, and really showing us ways in which, more research needs to be done in these areas, but also maybe there's some sources for potential interventions. So another really interesting concept in this area is thinking about treatment and how it may lead to changes in sexual roles or changes in sexual identity. So there's a study that was done in 2017 where they were looking at pre and post treatment positioning, and they kind of found changes in from insertive partners or tops and receptive partners or bottoms. And they saw some changes in that, positioning based on or after surgery or radiation. And so these changes in sexual role can really lead also to a loss of sexual identity. And you can imagine, there are some men that are able to switch roles, as based on their sexual interest or desire or resilience, and others aren't. And so for those that did not switch, some of the reasons they may include, insertive partners view switching to receptive as taking on a more submissive instead of dominant role, or not finding the new role pleasurable, or they're in relationships with partners who just, exclusively are only interested in one role. And so these shifts in sexual identity may be very specific to sexual minority men, and these need to be explored more. But I think we also, and a lot of what we've talked about so far has been, kind of thinking about disparities, but actually this repositioning may not necessarily be all negative. This also could show, this sorts of resilience in this group among sexual minorities. And so that's another really interesting topic that some folks are thinking about in this field. And so these kind of interesting findings on survivorship and disclosure led my group to conduct a qualitative study to generate more hypotheses around for survivorship experiences of gay and bisexual men in the space, and I'll talk about that in a moment. But another interesting point that we must make is that the heteronormative clinical environment may sort of impede research on prostate cancer among sexual minority men. And we see that patient-reported outcome measures for erectile dysfunction, for example, measures erections for vaginal sex. And these instruments were commonly used to assess sexual function and developed in cohorts where the sexual orientation of the participants was kind of unknown or validated in predominantly heterosexual cohorts. And then the identification of erectile dysfunction in these scales describe kind of erection stiff enough for vaginal sex. That is the actual definition. And so this may pose a problem when thinking about anal sex that may require firmer erections. And then also sexual functioning scales do not measure post-operative anal functioning. There was a study done by a colleague of mine who showed that the prostate as a source of sexual satisfaction, around 64% of all sexual minority men stated that the prostate was a source of sexual satisfaction, and around 100% of those engaging in receptive anal intercourse felt that way. And so it's really interesting to think that, for men who engage in receptive anal intercourse, sexual pleasure may be derived from, other sources and not necessarily, so erectile dysfunctioning may not necessarily be as high on their list of sexual functioning. And so we need to include, more data on sexual functioning in terms of anal functioning. And then finally, too, here to describe this kind of heteronormative clinical environment that we have here is that these prostate cancer support groups that have been around for a long time have been really a support for heterosexual men, have provided a lot of educational materials and social support for their treatment decisions and for their post-treatment side effects. And many of those support groups nationally are not necessarily attended or by sexual minority men or have educational materials that are tailored to sexual minority men. And largely, those support groups reflect the experiences of heterosexual men. There is a growing body of work, and I think that ZERO is kind of doing some work in this area of increasing the amount of support groups in minority groups, but that this is an area that's really necessary moving forward. So we completed a qualitative study to look to try to understand and generate hypotheses for future research. And I'll go through this fairly quickly, but we wanted to understand the prostate cancer care experience through a variety of domains. We wanted to understand the experiences of diagnosis and treatment for gay and bisexual prostate cancer survivors. We wanted to understand their medical decision-making, their emotional, physical, and sexual impact of treatment, and their support needs and partnership dynamics. In order to do this, we conducted focus group sessions in order to elicit responses. And some really interesting themes came up, and I'll show briefly here a couple of them. Great. So other emergent themes that came out are this need for disclosure, which we've talked a lot about disclosure here in this talk already. And one of the statements from one of the participants was the following. To me, disclosing sexual orientation, that's just a part of my health history. Yeah, I'm 5'8" and I weigh 175 and I'm gay, but this is just consistent with most things, making sure that the provider was going to be gay friendly. And then another participant had the following to say. Then, as opposed to my urologist who was straight and couldn't really identify with, what are some of the results of the surgery might have, not from an experience perspective, but what that might mean for me. What happens if you're a top or a bottom? What happened, right? So both of these quotes talk about or outline sort of a need for disclosure in the clinical setting. And then also we found a theme of a lack of tailored educational materials. And so one participant who was going through Kegel exercises following his treatment and was trying to do the Kegel exercises in terms of incontinence or dealing with incontinence. And he said the following. When they give me my preoperative packet, they gave me the literature on how to perform Kegels as a woman. I said, well, no, because I can't sit on the floor and suck a marble into my vagina. She said to me, well, I'm sorry if that's the information that you got. So this is really indicative of a lack of a tailored educational materials and even in this group for various purposes. Finally here, and we'll stop here after this theme, we found another kind of change in sexual identity after treatment. We've talked a little bit about, treatments with, talked a little bit about sexual role switching, but we see here other quotes of sexual identity. And I'll just talk a little bit here about the second quote. So you don't have enough time to talk about the shifts in identity with this disease. And not only that, I was thinking, if you're in a relationship, then how your relationship changes, right? And so really these types of things in terms of how the treatment, affects both relationships, your identity within that relationship is really important. And then these types of changes in sexual identity may be related to the widespread sexual dissatisfaction and isolation in this community following treatment. And so we need more research into sexual renegotiation and identity and reevaluation following treatment. How do men make decisions about role switching or engaging in other sexual behaviors like sensuality and touch? So finally, we have many ongoing gaps in our knowledge, and this is not an exhaustive list by any means, but these are some really areas that my lab is really interested in pursuing in next steps. So we really want to understand the prostate cancer experiences in other diverse populations. So sexual minority, people of color, also transgender women, and then also resumption of anal intercourse following surgery or radiation. What is the ideal or optimal period for each of these? And currently the field is in much debate. And then finally, do partnered or married sexual minority men achieve the same survival benefits as partnered or married straight men? We talked a lot about the survival benefits of marriage earlier in this talk, and really trying to understand if sexual minority men have the same care navigation from partners, if they have the same social supports as heterosexual men have. And with that, I think we've reached the end of our talk. I just want to acknowledge some folks that have been really influential in helping with this research, and thank you for your time.